Uh, Thank you so much. And sir, felicitation के लिए सर डॉक्टर जुमानी को सर बाहर हम ready है. Good morning all. Thank you so much for being here. I pay my pranam and respect to all. Dr. K.K. Tripathi sir is here. Thank you so much, sir, for being here. And I am privileged and honored to start the new session, specifically on type 1 diabetes and its management. And type 1 diabetes is emerging like as a new pandemic for India. And we have all faculties, all the dignitaries on board with us in Varanasi, first time in Varanasi. We have Dr. Rishi Shukla sir here, and Dr. Saurabh, Dr. Subodh sir, and Dr. Deepak Dalal sir here, who is going to take you for next 1 hour 15 minutes, specifically on type 1 diabetes. So just to begin, I would like to call our first speaker on this platform, Dr. Subodh Jain, who is going to present very insights on specifically on insulin intensification and thoughts. Thank you, sir, and please come on the rise. Thank you.
Very good morning and pranam. I can see here the great dignitaries, Professor Sir, Dr. K.K. Tripathi sir. सर आपके BHU में आज पहली बार मौका लगा मुझको बोलने का आपको सत प्रणाम. Dr. Rishi Shukla, Dr. Deepak Dalal, and I think Dr. Archana Sharda is not here. So the type 1 diabetes, may I have my slides? And but they are not. And first of all, I would like to congratulate and thank to Dr. Astosh Mishra, Dr. Pallavi Mishra for this wonderful CardiacCon conference on combined diabetes, cardiovascular risks, and the renal risk posed by the diabetes. My topic, first of all, I will be going for few basics to set the line for the speakers to follow me. The type 1 diabetes, of course, is becoming, as Ratish has said, that in pandemic proportions, and number of patients, they are increasing. In my college time, I used to see very infrequently type 1 diabetic. The whole of my MD career, I got only one diabetic ketoacidosis patient, aged 8 years, which I managed very judiciously. I will be talking about the next, of course, the slides are not progressing. Excuse me. No progression. Yes. So India is known as one of the epicenter of the global diabetes epidemic, and it's also a home to a vast population of children, adolescents, and adults with type 1 diabetes. Type 1 diabetes is characterized, we all know that there is destruction of pancreatic beta cell, of course, mostly by the autoimmune process. The type 1 diabetes is one of the most common chronic diseases of childhood, is also present in adulthood, when it's sometimes misdiagnosed as type 2 diabetes. As old as 90 years of age, the type 1 diabetes has been diagnosed. So in general, the younger the age of the diagnosis and longer the duration of type 1 diabetes, the greater is likelihood the individual will have absolute insulin deficiency with undetectable C-peptide levels. The incidence and prevalence of type 1 diabetes is suspected to be high in India. However, there is an absence of nationwide study. I think Dr. Rishi Shukla is there, and he has some insight in starting the type 1 registry in India. And I would like to have some discussion with Dr. Rishi Shukla sir for the type 1 diabetes registry. Data from the India reveals the significant prevalence of type 1, that is over 10 per 1 lakh population, with certain urban pockets reporting over 30 per 1 lakh population. The diabetic ketoacidosis is the first, in most of the patient, it is the first presenting symptom of type 1. Once DK has revolved in a newly diagnosed patient, therapy is transitioned to that of non-ketotic state. The children with previously diagnosed type 1 diabetes who develop DKA are usually transitioned to their previous insulin regimen after DKA is managed. The goals of the management, of course, the control of hyperglycemia and associated symptoms, reduce or delay the complications, and achieve a normal lifestyle and normal emotional and social development of the child, and achieve a normal physical growth and development, and detect associated diseases early. The most of the autoimmune diseases, they are associated with type 1 diabetes, and one should be able to diagnose them as early as possible, like vitiligo or the celiac disease and the autoimmune thyroid diseases which are present with type 1 diabetes. The management is the intensive diabetes therapy with the insulins. So intensive insulin therapy is the standard of care, and it includes the glycemic targets, the insulin replacement using appropriate regimens, which I will be talking in short, blood glucose monitoring. Diabetic education is of utmost importance, including the coordination of the meals and diet and with physical activity. The psychosocial issues will be dealt by Dr. Deepak Dalal in detail in a short while. Please. So the insulin replacement for the type 1 diabetes is the goal of insulin therapy is to provide physiological profile of insulin by administration of basal insulin plus boluses at meal time. So this physiological replacement with basal bolus therapy should be started as early as possible in a type 1 diabetic patient. And what is the clinical evidence? The DCC was the very long-term, the first trial, and it was a robust trial, and its long-term follow-up study that showed that compared with the simple or the conventional insulin regimen, early aggressive insulin therapy decreased the complications of type 1 diabetes. It has clearly shown reduction in microvascular diseases like retino, nephro, and neuropathy, as well as cardiovascular diseases and mortality. Early aggressive insulin therapy helped to sustain endogenous insulin secretion, which was associated with lower A1C and a lower risk for severe hypoglycemia. And what was considered at that time in 1990, intensive therapy in DCCT trial is now considered to be the standard care of therapy in the management of type 1 diabetes, as it has been given in the ADA standard of care by 2023. So the clinical evidence, it shows that in DCCT, definitively the stringent blood glucose control for an average of 6.5 years could show or postpone the progression of the retinal, renal, and neurological complications. The epidemiology of diabetes and its complications, that is EDIC trial, showed the impact of this improved diabetes therapy for an average of 6.5 years had long-lasting effect, that is the metabolic memory, and there continued to be improvements in the microvascular complications 4 years after the DCCT ended. The first part of my talk, the initiation. So the initiation of the insulin, of course, we know that each and every patient of type 1 diabetes needs insulin and nothing else. So the choice should be made after considering the personal preference, lifestyle, and of course the cost is most important in starting the insulin therapy because it has to be taken lifelong. There can be the different modalities, the multiple daily injections, MDI, and amongst the MDI, rapid acting insulins plus long acting insulins we can give. The continuous subcutaneous insulin infusion can be particularly benefit in adults with variable basal requirements, and unpredictable or varying schedules requiring flexible insulin dosing, and in those who had not been able to achieve their glycemic goals on MDI. So it is very easily said that patients should be put on insulins, but it is very difficult to practically give insulin therapy. So we need the whole team or the array of staff, the trained diabetes specific nurses and the supporting staff, and there should be so many sessions, at least 4 sessions, few weeks apart each session, and each session it is emphasized that how to give insulin, what should be the proper regime. In the first session, the patient or the caregiver or the parents, they should know what is the diabetes, what has led to their child development of the type 1 diabetes, the sites of injections, what type of insulins, how they can be given, the timing of the injections, the site rotations, where the recognition and management of the hypoglycemia and hyperglycemia, self-monitoring of blood glucose and whatnot. So in the session 2, which is 2 weeks apart after the insulin initiations, there should be the review of the injection techniques and review of the information provided in the session 1. The session 3, which should be the 4 weeks apart after insulin initiations, there is further information is provided, like how to take insulin on holidays or while traveling, the insulin injections when traveling through time zones, and the insulin management during the period of acute illness, foot care and other diabetes related complications, and how to manage them. In session 4, the review of the previous sessions and assessment of the glycemic control and need for further doctor and nurse follow-up. So the various regimens are there. We usually follow in most of our patients the multiple daily injections. So regardless of the type of insulin chosen, these insulin regimens should be monitored with blood glucose monitoring and maybe the continuous glucose monitoring systems. So almost each and every patient, we should try to put him on the basal bolus regimen, and the basal, in designing an MDI injection regimen, approximately 40 to 50% of the total daily dose should be given as basal insulin, either in OD, degludec, or U300 glargine, or OD or BD, U100 glargine or detamir, as a BD intermediate acting insulin and pH. This can also be given. The basal insulin can be given either at bedtime or in the morning, and pH is usually given as approximately 2/3 in the dose in the morning and 1/3 in the evening. Boluses or the prandial insulin, the remainder of the total, that is 60 to 50% of the dose of total daily dose, should be given as short acting, ultra rapid acting or rapid acting insulin divided before meals. So pre-meal dosing is determined by the pre-meal glucose level, the meal size and the content, as well as the activity and the exercise pattern of the patient. So regimen that use NPH in the morning may not require a pre-lunch dose of bolus insulin, because the peak of the NPH action occurs at the lunchtime. So the dose calculation determining the initial total daily dose. Most adults with newly diagnosed type 1 diabetes can be started on a total daily dose of 0.2 to 0.5 units insulin per kg. Although many will require 0.6 or 0.7 units subsequently. The starting dose can be adjusted upward or downward every few days based upon the symptoms of blood glucose measurements. The intensification is of utmost importance, and the diabetic specific nurse or the doctor himself should give time to make the caregiver understand that they need to, it's just initiation of the doses and they need to intensify. Most of the doctors, they fail to emphasize this point, and most of the patients, they come in the follow-up and they say they are giving the same dose which has been prescribed earlier. They do not intensify. So this is the pitfall which we should address. The adolescent, especially during the puberty, as well as adults with infections or other acute medical conditions or stressors, they often need high dose requirement. So these are the few regimens which we can follow. The regimen number 1, the rapid acting analogs plus NPH in the breakfast, that is pre-breakfast. Lunch we skip because of the NPH given in the morning. Then at the time of dinner, the rapid acting, and the at bedtime, NPH alone. Second regime, the 3 times rapid acting analog plus NPH at bedtime. The third regime, the similar, but we can give at bedtime the glargine, detemir, or the degludec. In the fourth regime, we can give the rapid acting analog pre-breakfast along with the glargine, detemir, or the degludec. And at lunch and dinner, we can give regular acting insulin. The fifth regime, the rapid acting plus the glargine, which is the U300, plus detemir or degludec, and then at lunch rapid acting, and again this U300 glargine can be repeated at dinner also, or the detemir we can give twice. So these are the 5 regimens one can follow and can achieve a good control. The choosing or now the optimization of the right insulin. First we will take the basal insulins. The glargine in adults with type 1 glycemic control is similar to once daily. The glargine is given before breakfast or before dinner or at bedtime. But there is less nocturnal hypoglycemia has been seen with breakfast administration. The U100 glargine, although a single daily injection can be given in the morning or evening, that is not always the case. Some people with type 1 diabetes we have seen that achieve better glycemic management when it is given twice daily, as it has got a half-life of 12 hours. U300 glargine, it is a concentrated formulation and duration of action is prolonged and it has further flat profile. This insulin is given once daily and can be benefit for some adults with type 1 diabetes. It may reduce the hypoglycemia in individuals with type 1 diabetes. The detemir, though we use very less now, detemir, the duration of action is shorter, approximately 16 hours, and though is still somewhat longer than NPH. Like NPH, twice daily injections appear to be the necessary for the detemir. Degludec is a very long-acting basal analog, available in U300 and U200 formulations. It administered once daily at any time of the day. The degludec may be mixed with rapid acting, that is Rhizodec, available without appreciably altering the kinetics of the either, whether fast acting and the long acting. The long-term safety profile is unknown, and in Europe the degludec is licensed for the use in children with diabetes aged 1 to 17. The newer insulin, which is going to be launched in UP also very soon, and I think Dr. Rishi Shukla will be there in Lucknow with the launch of insulin Icodec. It is a once weekly basal insulin analog. In the late phase of clinical development, it has got the similar efficacy and safety of Icodec to once daily glargine. The Icodec is analog of the human insulin with 3 substitutions at amino acids in B chain 14, 16, and 25, and it is has an attached C20 icosane fatty acid chain, and it binds reversibly with the albumin, similar to the insulin detemir, prolonging the half-life to 196 hours, that is approximately 7 days, achieving a steady state after 3 to 4 once daily injections. 3 to 1 weekly injections, sorry. 1 unit of the Icodec provides the same glucose lowering as 1 unit of the comparator of daily basal insulin, with an equivalent once weekly dosing being 7 times that of the daily basal insulin. There is evidence, of course, in the onward 6 trials that type 1 diabetes, they have shown that it is equally efficacious as the once daily basal insulin. The prandial, of course, optimizing the prandial insulins, they can be injected 10 to 15 minutes before and no later than immediately after meals. They can also be given, have a shorter duration of action and reducing the hypoglycemia. They are particularly useful in addressing unexpected high blood glucose levels. The ultra-acting insulins like Fiasp and Limjab, they are also available. The regular insulin, it is generally not used in type 1 diabetes. However, it can be used if there are cost concerns. But here we use mostly the regular insulins. The factors affecting the bioavailability and the absorption rates of subcutaneous, there are so many factors. The site of injections, the abdominal injections, they are most common one and results in the quickest absorption. Arm injections, they are quicker than in the thigh and the hip injections. The depth, of course, they have to be given subcutaneously, but the intramuscular injections can lead to rapid absorption. The concentration, the concentrated insulins, they have got longer onset of action. The insulin dosage, the higher the doses, the prolonged the duration action will be there. Mixing, of course, once we use the regular with the NPH, they maintain its potency and the time action profile. Devices, insulin pens, of course, the several insulin pens allow the convenience of half unit dosing, a critical need for the pediatric patients and those adults with high insulin sensitivity and low insulin requirements. So the advantage, the continuous subcutaneous insulin infusion, that is about the insulin pumps. They remain the gold standard for the type 1 diabetic patients. The modern insulin pumps are much smaller and are easier to use than the pumps of the past. The advantage, they mimic the normal physiological insulin secretion. The basal insulin infusion rates can be programmed throughout the 24 hours day. The basal rates can be adjusted to match the lower demands for night, that is between 11 a.m. to 4 a.m. and the higher between the 3 a.m. to 9 a.m. So as with the MDI, the correction doses can be provided before or even between meals. It can accommodate metabolic changes related to the eating, exercise, illness, or varying work and travel schedules by modifying the insulin availability. So the designing, of course, the total dose is calculated and the hourly rate can be given by dividing the total dose by the 24, the basal dose. And when switching from long-acting insulin to the insulin pump, the total basal dose should be reduced by the 10 to 20%. The prandial dose depends on the anticipated amount of carbohydrate eaten and will be ingested, and the prandial blood glucose concentration. The converting from MDI to insulin pump therapy, the conventional therapy of the initial dose is dependent on the diabetes control and total daily dose of the insulin. The control has been excellent. The initial dose can be reduced to 10 to 20%. If control is poor, the previous total insulin dose should be used. The honeymoon phase, a few weeks after the diagnosis, the initiation of insulin therapy, a period of decreasing exogenous insulin requirement occurs. This is commonly referred as honeymoon. I will take just 2 minutes or. And the remaining functional beta cells secrete some endogenous insulin. So close monitoring of blood glucose is mandatory in this phase, and stringent A1C target is recommended with close monitoring. Duration of this phase is variable from several months to years. So adjustment with the growth, they are the important factors which should be considered in young patient. Follow-up visits at least every 3 months are required. As child enters into the puberty, daily insulin requirements may increase from 1 to 1.5 unit per kg. There should be the adjustment to the regimens at every follow-up. The total insulin doses after honeymoon phase is between 0.7 to 1.5, and a typical range of pre-pubertal children 0.7 to 1 unit. Very young children may need lower doses. During puberty, the daily required rises up to the 1 to 1.5. The pre-pubertal children require a higher basal rate in the early part of night, while post-pubertal adolescents who experience the dawn phenomena require a higher rates in the morning. So a lower rate between breakfast and lunch is there, as they are sedentary at school, and a lower rate of a variable period after exercise is required. So The boluses can be administered in a dual wave or a square wave. Those who are using insulin pump, they all know about this varying variable rates. So incidence and prevalence of type 1 diabetes in children is increasing, hence appropriate management is crucial. The type 1 diabetes management has advanced with rapid and long-acting insulin analogs, insulin pumps, and continuous glucose monitoring and improving patient outcomes. Strict glycemic control, as shown by studies like DCCT, helps in prevent type 1 diabetes complications. Ongoing research focuses on non-insulin therapies like incretin agents, SGLT2 inhibitors, and advanced technologies such as artificial pancreas system and smart insulin delivery systems. These patients and their families need a lifetime and intensive diabetes education, monitoring, management of hyperglycemia, and complication of lifestyle psychological support. The field of type 1 diabetes is evolving rapidly, aiming for personalized care to enhance glycemic control and quality of life for the patient. Thanks for the patient hearing, sir.
Thank you, Dr. Subodh sir, for their comprehensive talk on the optimization of insulin therapy. Is any question from audience side?
Thank you, sir.
Thank you, sir. Thank you for this comprehensive talk. And I'll just